Dr. Gobi Mohan in his absence. Thank you, sir, for joining. And I would like to welcome Antakesavan sir, Scientific Coordinator, Mohan Das sir, State Coordinator, and Dr. Shiji, who is traveling and so may not be able to join. I would like to welcome our faculty, Dr. Sereena, for a senior consultant from Rajagiri, who is the faculty. And our mentor is Dr. Sunil, Professor, Medical College, Ernakulam. Also welcoming our star of the day, Akshaya Venkatesh from Medical College, Ernakulam. Today, the floor is yours and good luck. And welcoming all senior teachers and students like Purushothaman sir, who makes every attempt to join every week, and who all those who have logged in today. And happy learning over the next 1.5 hours. Thank you.
B. Okay. Thank you, Abhi, for those nice words. So, like Abhi told, all of us are so happy that our students were participating in very good numbers. Today, we all expected a drop because the exam has started yesterday. But the wonderful thing about this particular program is now when there is a class, I actually do my revision going to the IAP website and looking at the archives, because any topic you choose, there is a very excellent discussion on the topic which is available at our fingertip. So I want all our postgraduates to use your time. Whenever you are free, we can revisit all these classes. So we have actually created a good archive of clinical case discussions, and please make use of that. And I'm so sure that this program is going to continue in the coming years also, because we have teachers like Purushothaman sir, Anandageshwar sir, Mohan Das sir, who is actually giving their heart to this program. And they are the ones actually make sure that it goes without any hindrance. So with that words, I once again congratulate IAP Cochin team for organizing this episode of the program. And I'm very happy that two of my friends only, Dr. Sereena and Sunil, Dr. Sunil are handling this session. And the best wishes to the teachers as well as the student, Dr. Akshaya. Thank you. Abhi, വേറെ എന്തെങ്കിലും പറയാനുണ്ടോ? അല്ല, ആനന്ദോഷൻ സാറ് ആനന്ദോഷൻ സാറിന് ഒരു വാക്ക് പറയണമെങ്കിൽ സാറോട് പറഞ്ഞിട്ട്
we can start. I think we're already late. Yeah, very good teacher. We are waiting for Sereena and Sunil Daniel to hear from them.
Okay, so I think Sereena can.
Over to Dr. Sereena.
Hello everyone, good evening. I think we'll straight away go with the discussion. I think Dr. Akshaya can start with the case presentation.
Is the screen visible, Sereena? Am I audible?
Volume കുറവാണ്.
Volume കുറവാണ്, audible അല്ല.
Am I audible now?
Volume കുറവാണ്.
ഒരു മിനിറ്റ് സർ.
കുറച്ചും കൂടെ അടുത്തോട്ട് ഇരുന്നാൽ മതിയായിരിക്കും അക്ഷയ, കുറച്ചും കൂടി ഡിവൈസിന് അടുത്തോട്ട് ഇരുന്നാൽ മതിയായിരിക്കും.
സർ ഇപ്പൊ കേൾക്കാമോ?
വെരി ക്ലിയർ.
Okay.
സ്ക്രീൻ കാണാൻ പറ്റുന്നുണ്ടോ സർ?
Yes.
A very warm good evening to all faculties. So can we proceed with the case presentation?
Akshaya, you're not very clear.
Ma'am, can we proceed with the case presentation?
Yeah.
Am I audible now, ma'am?
Yeah, now you're audible.
So moving on to our case discussion, I would like to present Iza, 2-year, 11-month-old girl hailing from Ernakulam. Informant is grandmother. Grandmother is the primary caretaker of the child, hence information is reliable. So presenting complaints, Eza had come with chief complaint of nasal discharge and cough since 3 days, puffiness around eyes since 2 days, swelling of both feet since 1 day, and abdominal distension since 1 day. Eza, as per the grandmother, was diagnosed with a renal disease at 1.5 years of age, which she describes as nephrotic syndrome, and she's currently on medication for the same with good compliance. The nasal discharge and cough was insidious in onset to start with, dry sounding, non-paroxysmal, not associated with post-tussle vomiting. There was no history of grunting, wheezing, or stridor. There was no diurnal variation or postural variation. It was also not associated with fast breathing. Puffiness around eyes was insidious in onset, gradually progressive, more during morning hours and decreases as the day progresses. It was initially in the periorbital region and later progressed to the whole of face. Swelling of both feet was gradually progressive in nature and progressed to generalized abdominal distension. History of frothing of urine and decreased urine output was also noticed by the grandmother during the course of illness. There was no history of cola-colored urine or reddish discoloration of urine, no history of headache, irritability, altered sensorium, convulsions, or any neurological deficits noted, no history of fast breathing or dyspnea on exertion, no history of jaundice, poor appetite, or itching, no history of increased crying during micturition or increased frequency of micturition, no history of other drug intake, no history of fever, rash, joint pains, or oral ulcers, no history of diarrhea, vomiting, abdominal pain, no history of pain or redness of limbs. For these complaints, Eza was admitted in the ward and started on daily steroids and supportive measures for edema. Since these complaints began...
Akshaya, I'll just, Akshaya, can you hear me?
Yes, ma'am. Yes, ma'am.
Yeah. So after the history of presenting complaint, so you have presented like the child has a cough, cold, and puffiness and generalized edema, right?
Yes, madam.
Yeah. So, so you have described the respiratory infection. The child has a respiratory infection, presented as a respiratory infection, right?
Yes, yes, ma'am.
And you have also mentioned that the child is a known case. She's a known case of nephrotic syndrome. So this must be a relapse, right?
Yes, ma'am. Yes.
Yeah. So you have given a detailed negative histories. So what are the negative histories that you have elicited? Like,
yes.
Yeah.
So, ma'am, with respect to the cough and nasal discharge, the negative histories elicited with that was there was no fast breathing, there was no grunt, or there was no stridor. So I like to mention that there was no pneumonia associated with it or any danger signs associated with it. Then with respect to the other negative history, that there was no reddish discoloration of urine or cola-colored urine, that is, there were no nephritic related picture associated with the complaints. Then I also mentioned...
Yeah, overall, you can divide that into like, first you are telling the respiratory infection. You have described this beautifully as an upper respiratory infection. There was no significant chest signs or any wheezing episodes or a wheeze-associated lower respiratory infection. So that is just an upper respiratory infection.
Yes.
The second point is about the edema. So you can adjust. You can write in such a way that you have first described edema, and you have described beautifully as the edema is like a renal edema. So some of the negative histories are like you are ruling out other causes of edema. So group those into a single, like you are ruling out other causes of generalized edema like hepatic, all those things, UTI, all those things, diarrhea, you have written like that. And second, after that, you can describe, you can give a negative history of the complications.
Yes, ma'am.
Okay.
Yes.
So now we have discussed what is a presenting complaint, how it is presenting. You've discussed, you have ruled out other causes of edema, and you have told that the child doesn't have any complications of the nephrotic syndrome in this present episode.
Yes, ma'am.
Okay, now we'll go to the past history.
Thank you, ma'am.
Yeah.
So, moving to the past history, complaints started at the age of 1 year and 6 months, that is in August 2024, when child had presented to the OPD with chief complaints of fever since 2 days, facial puffiness, and lower lip swelling since 1 day. So for these complaints, child was initially brought into the OPD, and hence routine blood and urine workup was done for the complaints mentioned. So urine workup done initially showed abnormally high levels of protein. Hence, child was admitted for detailed workup. However, at admission, child was active, alert, with stable vitals. But by day 2, while child was admitted in the HDU, child suddenly developed one episode of abnormal movement in the form of uprolling of eyes and stiffening of all 4 limbs, which lasted less than 5 minutes, followed by a period of unresponsiveness for 1 hour. Hence, child was immediately shifted to the PICU. On receiving at the PICU, child was unresponsive and noted to have low blood pressure, and hence was given 2 IV fluid boluses and later started on an expensive medication which the grandmother mentions as albumin. BP and the blood pressure and sensorium normalized with IV fluids and albumin, and child didn't require any medications, that is inotropic support, in order to increase the BP or any anti-seizure medications later on. Urology opinion was sought in view of seizures at that time. However, in view of hemodynamic instability, EEG and MRI was planned later on. Then by day 3, urine tests were confirmatory for nephrotic syndrome, and hence child was started on oral steroids. Child had difficult peripheral line access difficult peripheral line access. Hence, IV medications and anti-edema medications were changed into oral medications by day 3. However, by day 5, child continued to have severe edema and was not responding to oral diuretics and steroids. Hence, a central line was placed in the right lower limb, and oral medications were changed into IV steroids and IV diuretics for 3 days. By day 9, child developed edema and painful movements of right lower limb. Hence, ultrasonography of the right lower limb was done, which showed thrombosis of multiple lower limb veins, that is DVT, and hence treatment was started for the same. Child was initially started on injection of polyethylene heparin for the same for 2 weeks, followed by oral warfarin for 12 weeks. Repeat scan was done after 3 weeks, which showed recanalization of the lower limb veins. Urine tests were normal after 2 weeks of hospitalization. That is, the albumin was nil for 3 consecutive days by day 12 of hospitalization, and hence thereafter child was continued on daily medication for another 4 weeks, that is a total of 6 weeks, and later alternate day medications for another 6 weeks. MRI was done after 2 weeks, which was found to be normal. So the first relapse.
Okay, so Akshaya, during
Yes,
the first episode, it was not a very peaceful course, right? The child developed some complications.
Yes,
so the child developed some seizure-like events on day 2. So
Yes,
what do you think? What do you think can be the or what all causes can be there to cause a similar episode in a child with nephrotic who's been diagnosed with nephrotic syndrome?
Yes, ma'am. It could be dyselectrolemia, electrolyte imbalance could be one of the causes.
Yes.
Or if the RFT was deranged uremic encephalopathy, it can be one of the cause. Or if at that time, in this case, hypovolemia could be one of the cause due to decreased perfusion. But if the BP was on the higher side, it can be an hypertensive encephalopathy like picture, which was not in this child's case.
Okay. Something else?
Something else like if it is a thrombosis, then we'll have to consider cerebral vein thrombosis now.
Yes. Okay. Okay, that can be a thrombotic stroke also.
Yes, ma'am.
Yeah, good.
So can I continue, ma'am?
Yeah, sure. And one more thing, the child also developed this DVT because the child is prone to thrombosis.
Yes, ma'am.
Yeah, because why do you develop thrombosis in a nephrotic syndrome child?
Because there is, along with albumin, there are other proteins which are lost in the urine, like antithrombin C, protein S. So overall, there is a hypercoagulable state. The liver also secretes, to compensate it, there are more lipoproteins which are secreted. So
Yeah.
all this contributes to a hypercoagulable state.
Yeah, good. And because the child, you're losing a lot of protein in the urine, you develop something else also, which is very common in nephrotic syndrome. Infections.
Infections, yes, ma'am.
Yeah, okay. Okay, good. Yeah, continue.
So moving on to the first relapse, that is after 9 days of stopping alternate day medication, child again developed similar complaints and had a stormy PICU stay. Initially, child had presented with similar complaints of periorbital puffiness triggered by an acute lower respiratory tract infection. But in that hospital stay also, child was noted to have low blood pressure, requiring 2 doses of expensive medication, that was IV albumin and fluid boluses. And child was treated as first relapse for that episode. Child attained remission by day 30 and was discharged on alternate day medications for 4 weeks. However, while the child was on 9th day of alternate day therapy, child again developed similar complaints of eyelid puffiness triggered by an upper respiratory tract infection. For the same, child was again converted into 60 mg per meter square steroids, and it resolved after 6th day of daily medication. So since child had 2 consecutive relapses, pediatric nephrology opinion was sought for the same, and child was planned on long-term alternate day prednisolone therapy. But on day 28 of alternate day steroids, child developed third relapse triggered by an acute lower respiratory tract infection. Hence, again, the steroids were converted into 2 mg per kg daily steroids, and child attained remission by day 6, and thereafter was continued on alternate day steroids at 1.5 milligram per kilogram. The fourth relapse was again triggered by an insect bite while child was on alternate day steroids at 1.5 milligram per kilogram. Hence, a daily dose, like a stress dose of 1.5 mg per kg was given to the child until child attained remission by day 6. So this was the graph. The initial complaints began in August 2024, where the first episode of nephrotic syndrome, child attained remission by day 12 and had completed 6 weeks of daily steroids and 6 weeks of alternate day steroids by November 2024. However, after 9 days of stopping steroids, child developed the first relapse, that was in December 2024, and child attained remission by day 13. But within 9 days of alternate day steroids, child went into second relapse. And during the second relapse, child attained remission by day 6, and child was continued on alternate day steroids. And on the day 28 of alternate day steroids, child went into third relapse, from where child attained remission on day 6. Then child went into fourth relapse while thereafter child was planned on slow tapering of steroids. By the 6th week of 1.5 milligram per kg, child went into fourth relapse, where child was given stress dose of steroids, and currently child is on fifth relapse of nephrotic syndrome.
Okay, so what is a relapse?
So relapse is when urine protein urine protein for 3 consecutive days is 3 plus or 4 plus, or urine PC ratio is more than 2 milligram per milligram.
Yeah. So in this patient, what are the 2 types of relapse?
Yes, there is frequent relapse and infrequent relapse. So this child falls under the category of frequent relapser. So frequent relapser is in the first episode of diagnosis of nephrotic syndrome. In the first 6 months, if there are 2 relapses, or if there are 3 relapses in any 6 months, or total of 4 relapses in a year. So this child falls under the category of frequent relapser, madam.
Yeah, okay. Okay.
And
yeah.
this child also falls under the category of steroid dependence.
Yeah.
Because
what is that? Yeah.
So steroid dependence is when within 2 consecutive relapses while on alternate day steroids or within 14 days of stopping of steroids. So this child had first went into relapse on the 9th day of stopping of steroids, and there were also 2 consecutive relapses while on alternate day steroids.
Okay. So when do you say a child has a steroid resistance?
So steroid resistance is when child has not attained remission. According to ISBN, when child has not attained remission even after 6 weeks of daily steroids at 60 mg per meter square or 2 mg per kg per day.
Yeah, good. Okay, you continue.
Thank you. So past history continued of the first illness. There was no history of any contact with tuberculosis. There was no history of recurrent urinary tract infection. There was no history of blood in urine. There was no history of rash or joint pain. There was no history of jaundice or blood transfusion in the past. There was no history of failure to gain height. There was no history of any excessive weight gain, behavioral changes, visual disturbance, or any muscle weakness noted. There was no history of any failure to thrive or steatorrhea noted. Moving on to the antenatal history. Can I proceed, ma'am?
Yeah, sure.
So moving on to the antenatal history, child is a firstborn child out of a non-consanguineous marriage. Mother was 20-year-old preemie, father 23-year-old. There was no history of any recurrent abortion. It was a natural conception, booked case, regular antenatal checkups done at a private hospital. Preconceptional folic acid were not taken. So moving on to the antenatal history, first trimester folic acid was taken regularly. There was no history of fever with rash and arthralgia, no history of spotting per vaginum, no history of radiation exposure or drug intake, no history of hyperemesis gravidarum. Moving on to the second trimester, quickening was felt at 5th month. Antenatal scans were found to be normal. There was no history of any intrauterine growth retardation, no history of gestational diabetes mellitus or PIH, no history of anemia. Calcium and iron tablets were taken regularly, no history of oligamnios or polyhydramnios. Moving on to third trimester, a cumulative weight gain of 13 kg was noticed during pregnancy. No history of any increased or decreased fetal movements. No history of any spotting PV or any lower abdominal pain associated with foul smelling liquor. So birth history, baby was born term, normal vaginal delivery with a birth weight of 2.6 kg. Baby had cried soon after birth. Postnatal period, no history of any NICU admission. Baby was breastfed within 1 hour of life. Urine and meconium passed within first 24 hours. No congenital malformations were noted. Baby was feeding well and gaining weight and was discharged on postnatal day 4 with an uneventful hospital period. Developmental history, child has attained a developmental quotient of 100% in all milestones, in all developmental domains. Vision and hearing is normal. Immunization, child has taken all vaccines according to the national immunization schedule till 1 year and 6 months of age. There was no adverse events following immunizations noted. BCG scar is present. However, child has not taken any optional vaccines.
What are the optional vaccines that you advise, or what will be your immunization advice to this particular child?
Yes, ma'am.
He's now 2 years and 3 months, right?
2 years and 11 months right now, ma'am.
11 months.
So
Okay, yeah.
this child was born in 2023. So child has taken the PCV doses. So this child, since if the child had presented after 2 years of age, we would advise an additional dose of PCV and PPSV 23. In this case, child will also need to be vaccinated with varicella. We'll have to give optional vaccines. Varicella and influenza vaccine will also have to be given to this child.
When do you give varicella?
Varicella has to be given after, since it's a live vaccine, it needs to be given after stopping of alternate day steroids, at least 4 weeks after stopping of alternate day steroids.
Okay. What about influenza?
Influenza vaccine has to be given annually, and it has to be given after 8 weeks of stopping of alternate day steroids.
How many weeks?
8 weeks, ma'am.
Why?
Since it's
What influenza vaccine do we give now? Is it a live vaccine or a killed vaccine or a live attenuated vaccine?
sorry, ma'am. It is an inactivated vaccine. So, like,
Yeah. So there is no time frame.
yes, ma'am.
Okay. Okay.
So, dietary history. So the child is observed to have a calorie intake of 1035 kilocalorie as expected of 1070. There is only a deficit of 35 kilocalories. Protein observed is 31 gram and expected is 20 gram. Diet currently includes 2 to 3 egg whites, no added salt in diet, and fresh fruits and vegetables, including green leafy vegetables. Family history. There is no history of similar complaints in the
So
family.
what? This is a 5th relapse, right?
Yes, ma'am. Yes, ma'am.
So what will be your dietary advice during different stages, like in remission, in relapse, and all that?
Yes,
this child is on no added salt. That is what you said.
Yes,
Suppose the child is in remission, what will be the dietary advice?
if the child is in remission, they can have normal diet, but they should not have high, since they're all they'll be off steroids by then. So they should continue to have a good quality protein in their diet. That is 1 to 2 gram per kg of good quality protein should be included in their diet.
Okay. And when the child is in relapse, do you advise salt restriction or is just no added salt?
We would say no added salt, ma'am. Salt restriction as it will depend upon the edema, ma'am. If there is a mild, if there is mild edema, then we will have to say 1 to 2 milliequivalent per kg. That should be the salt intake of the child. So there should be no added salt. But if there is moderate to severe edema, then salt restriction along with diuretics has to be given to the child.
Yeah. Okay. So the diet has to be streamlined depending upon the condition of the child.
Yes, ma'am.
Okay. Good. And you said about salt. What about the protein?
Protein should be good quality protein, ma'am. When we are advising egg, since the child is more prone for hyperlipidemia, the egg yolk has to be avoided. The egg whites can be given, and the protein intake should be 1 to 2 gram per kg per day. So more of egg whites, and even in the meat, white meat.
During relapse, I think you should have a higher protein intake, 2 to 2.5 gram per kg per day.
Yes, ma'am.
Okay. Good. Continue.
So family history, no history of similar complaints in the family. There is a history of bronchial asthma in the mother. No history of early onset renal disorders, renal replacement therapy, or any hearing loss or visual abnormality in any family member. No history of arthritis or rashes in the family.
So what all you're planning to, I mean, where you're rolling out from this?
Family history. So if there is any child with early on, basically we are trying, if there is any child with similar complaints in the family, if it is very early onset, there is any history of congenital nephrotic syndrome or infancy onset nephrotic syndrome, or anybody with nephrotic syndrome who has history of steroid resistance, family history of steroid resistance. So that is what we're trying to avoid. And again, any history of any early onset renal disorders, basically there can be other secondary causes of other renal disorders like SLE or HSP or IgA nephropathy. So any other renal disorders in the family requiring renal replacement therapy, and any hearing loss, if there is, we are trying a hearing loss visual abnormality like Alport or Potter's abnormality, all those disorders we are trying to pull out.
Yeah, basically you're trying to prognosticate whether the child will be responding to steroids or the child will be a steroid resistant child.
Yes.
Yeah, good, continue.
So socioeconomic history, the father's education, father has studied till polytechnic. Mother is a housewife who has completed up to college, undergraduate education, but however they are separated. Since mother abandoned the baby, she's being taken care by her grandmother and father. So modified Kupaswamy scale, they will fall under lower middle class. They have rented a pakka house with 2-room kitchen, separate toilet with adequate sanitary measures and clean water supply, no overcrowding. They are not beneficiaries of any government policies. Summary. So 2-year, 11-month-old girl with normal development, immunized for age as per national immunization schedule, diagnosed with nephrotic syndrome at 1.5 years of age, on medications, now admitted with chief complaint of cough, rhinitis, and periorbital puffiness with reduced urine output. So this would probably be a 5th relapse of frequently relapsing steroid-dependent nephrotic syndrome.
Okay.
So moving on to the general examination, child is comfortable in supine position. She is alert, febrile, playful. No pallor, icterus, cyanosis, clubbing, or lymphadenopathy noted. However, bilateral pitting pedal edema till knees was noted. Vitals, heart rate 112 beats per minute, regular in rhythm and normal in volume. All peripheral pulses were well felt and no radial or radiofemoral delay. Blood pressure was 90 by 60 millimeter mercury measured in the left arm in supine position. It lies at the 50th centile for age and sex. Capillary refill time was less than 3 seconds. Respiratory rate 28 breaths per minute. Temperature 98.6 degree Fahrenheit measured in the axilla. SpO2 98% in room air. Anthropometry.
What is the importance of recording this BP?
The blood pressure, ma'am, if the child has any if child is going into any hypertension or not, that is when the child is if the child has hypertension, it can indicate any nephritic like symptoms developing, or it can be because of steroid toxicity.
Yeah, but when the child is presenting to you in the acute
features.
phase, if there is no hypertension, even then you need to know whether the child is hypovolemic. That is very important, but because the child is having a, I think, moderate to severe edema in this present admission, and having the management of edema will differ depending upon whether the child is hypovolemic or hypervolemic, right?
Yes, ma'am.
So how will you treat edema?
Yes, ma'am. So edema, it will depend on, we'll have to categorize the edema if it is mild, moderate, or severe. So mild, so from the baseline body weight, if there is an increase of only less than 7%, that is mild edema. Moderate edema, when it is between baseline body weight increases between 7 to 15%, and if there is more than 15% increase in the baseline body weight, dry weight, then it is severe edema. So mild edema can be treated with salt restriction. And but however, if the child is in moderate to severe edema, we will initially we will have to give advice of salt restriction, and along with that we will initially start with oral diuretics, which will be loop diuretics, that is preferably oral furosemide. And if the child is not responding, then we will have oral diuretics, that's oral loop diuretics furosemide, along with spironolactone, that is potassium channel blockers. If the child is not responding, then we will add oral thiazide diuretics like metolazone. And if the child is still not responding, then we will have to convert it into IV furosemide with IV albumin. And if the child is IV furosemide will convert, and if the child is still not responding, then IV furosemide with IV albumin, and still if it is refractory, then ultrafiltration.
Yeah, is there any role for fluid restriction?
Fluid restriction, fluid intake will be always a previous insensible water loss and previous day urine output, ma'am. So we will.
Yeah. So when you treat edema, there should be the salt component, the fluid component, and the protein component.
Yes.
Okay. Continue. So what is the dose of what percentage of albumin do you give?
A 20% albumin, ma'am. And it is given 1 to 2 gram per kg. Started initially with 1 gram per kg.
Yeah, it's actually 0.5 to 1 gram per kg. Because if the child is having massive edema and you give a high dose of albumin, what will happen?
There will be suddenly all the interstitial fluid will be moved to the vasculature, and there can be fluid overload.
Yeah,
and
fluid
child can
overload
have
and pulmonary edema. Yeah. Yeah. Suppose you don't have 20% albumin, you have only 5% albumin. What do you do? What? So 5%, it will be like 10 to 15 ml per kg.
10 to 15.
Yeah. And 20%, it is 0.5 to 1 gram per kg.
Yes.
Yeah. Good. Continue.
So anthropometry, the weight for age observed was 13.4 kilogram. Expected is 13 kilogram. Normal according to the IAP classification. Height for age is 91 centimeters.
So at this point, when you take the weight, you should make sure that you should ask the parents what was the usual weight of the child prior to the episode. Then only you can say whether there is any this mild, moderate, and severe that you have said.
Yes.
Yeah. Okay.
So height for age observed was 91 centimeter. Expected is 93 centimeter. There is no stunting. Head circumference observed is 50 centimeter, normal for age. Mid upper arm circumference was 16.5 centimeter. Weight for height was 103%, no wasting. Height velocity was 4 centimeter from the last year, increase of 4 centimeter. Height age is 2 years, 7 months. Weight age is 2 years, 10 months. Chest circumference is 53 centimeter. Upper segment to lower segment ratio is 1.3:1.
Yeah. What is the importance of checking this height velocity in this particular child?
Since the child is on high dose steroids, ma'am, there can, as a part of steroid.
For the past 1 year, the child has been on steroids, right?
Yes, ma'am.
Yeah, good. Continue.
So this is the anthropometric chart plotting for the child. Weight for age, length or height for age, head circumference for age, weight for length chart, and the combined chart. So head to foot.
That's a normally thriving child, right?
Yes, yes, ma'am.
And when you say the anthropometry, you should say that the child is having 13.4 with edema.
Yes, ma'am.
Yeah, okay.
So head to foot examination, head shape and size, no microcephaly or macrocephaly noted, no dolichocephaly or brachycephaly. Hair, normal sheen, texture and color. Eyes, no cataract, no feature suggestive of vitamin A deficiency. Bilateral periorbital puffiness is noted. Ears, normal alignment and no anomalies. No preauricular tag or sinuses noted. Nose, nasal discharge was present. Tongue, moist. No angular stomatitis or cheilitis. No oral thrush. No Cushingoid features were noted. Neck, no buffalo hump or acanthosis. Chest, no pectus excavatum, carinatum, no Harrison sulcus. Abdomen, it was distended. No striae, transverse slit-like umbilicus was noted. Genitalia, no edema. Limbs, no redness or tenderness of limbs. Skin, no striae or easy visibility. No hypertrichosis, no tinea. So examination of the gastrointestinal system.
General head to foot examination, you looked at the edema, you looked at the deficiencies.
And we also looked for features of steroid toxicity.
Yeah, good. Continue.
Examination of gastrointestinal system, upper GIT, oral hygiene is good. Lips, no chelosis, cheilitis or angular stomatitis. Teeth, no caries. Normal dentition with 20 teeth. Buccal mucosa, no thrush or ulcers. Tonsils, no exudates, no erythema, no postnasal drip. Examination continued. Inspection of the abdomen, shape. Abdomen generalized distension present. Flanks appear full. All quadrants moves equally with respiration. Skin over the abdomen appears normal. Umbilicus was slit-like, smiling umbilicus. No dilated veins or scars. No visible peristalsis or pulsations. Hernial orifices are normal. External genitalia, no edema or fungal infections. On palpation, no local rise of temperature or tenderness or any renal mass noted. Liver 2 centimeter palpable from right costal margin. Soft in consistency, smooth surface and rounded borders. No renal angle tenderness. Spleen not palpable. Abdominal girth 52 centimeter was noted. Percussion, liver span was 6.5 centimeter. Shifting dullness was noted. No fluid thrill. Auscultation, normal bowel sounds heard over all areas. No brewing or venous hum. Genitalia, no edema or discoloration or fungal infection noted. Other systems, respiratory system, trachea was central. Movements of chest were bilaterally equal. Percussion, resonant in all areas. Tidal percussion, normal. Trough space, resonant. Normal vesicular breath sounds heard bilaterally with equal intensity. No added sounds. No wheeze or creps. Serious, JVP was not elevated. Apex was felt in the fourth left intercostal space at mid-clavicular line. S1, S2 was heard normally, no murmur. CNS examination, higher mental functions were normal. Cranial nerve examination, no deficits noted. Motor system, bulk, power, tone was normal and bilaterally symmetrical. All superficial and deep tendon reflexes were present bilaterally. So moving to the diagnosis. So ESA is a case of steroid-dependent high threshold nephrotic syndrome was in fifth relapse precipitated by upper respiratory infection. Etiology, idiopathic, probably minimal change nephrotic syndrome. No complications, no evidence of steroid toxicity, normal growth and development, fully immunized for age as per national immunization schedule. Okay. So moving to the investigation, urine analysis, urine albumin was 4+ for 3 consecutive days, pus cells 3 to 4 per high power field, RBC 1 to 2, spot urine PC ratio was 12.03:1, serum albumin was 2.1 gram per deciliter, urea creatinine 28 and 0.4, eGFR was 93.9, sodium and potassium 131, 4.5. Hemoglobin was 13 gram per deciliter. PCV was 39.1. Total count was 11,700 with neutrophils 82% and lymphocyte 18%. Platelet was 4.95 lakhs. Calcium, phosphorus 9.5 and 5.2 milligram per deciliter respectively. Total cholesterol was 252 milligram per deciliter. The blood cultures and urine cultures were sterile. SGOT, SGPT 35 and 47. Albumin to globulin ratio was 0.7. Additional investigations which were done at the
So what were the positive findings from these investigations?
Yes, ma'am. So urine albumin was consecutively positive for 3 days. That was 4+. Nephrotic range proteinuria was present. And spot urine PC ratio was also more than 2.
There was proteinuria.
There was proteinuria. Then the albumin, there was hypoalbuminemia. And there was also edema clinically noted. So which fits into hypercholesterolemia.
Yeah. So what other things? Sodium was 131. What would be the reason?
So it could be a dilutional hyponatremia, ma'am.
Okay. Yeah. What is the importance of PCV?
So ma'am, so if the hematocrit is on the higher side, it could always indicate a hypercoagulable state. So child will be more
hypercoagulable state, and the child may be
is a biochemical indicator for hypovolemia.
Yeah, good. And you've checked for calcium, phosphorus. Okay. Yeah, okay.
Because there could be hypocalcemia if, because of hypoalbuminemia.
Yes, okay, good. Yeah.
So additional investigations which were done at the first episode in order to rule out secondary causes, serology was done. So HIV, ELISA, anti-HBsAg, anti-HCV, all were negative. Manto test done was negative. Serum C3 was 100.95. The normal range is between 70 to 135, which was normal. USG abdomen was done. No kidney, ureter, bladder anomalies were noted or any significant abdominal pathology noted. Peripheral venous Doppler was done in view of right lower limb swelling and tenderness, which was initially suggestive of deep vein thrombosis of right common femoral, superficial femoral, and popliteal veins. Repeat Doppler done after 3 weeks showed recanalization of these veins. Ophthalmological evaluation done at 6 months of taking steroids. There was no evidence of any cataract or steroid toxicity. So a child is currently on 40 mg per meter square, 1.5 mg per kg of daily steroids, and is planned for slow tapering of alternate day oral steroids over 1 year as per pediatric nephrology opinion.
So the child was on 1.5 milligram per kg of daily steroids when this child got this fifth relapse. Is it so?
No, ma'am. Child was initially on, before this relapse, child was on 1.5 mg per kg of alternate day steroids. So
Okay.
this
Now after the remission, you have, so when do you start, like, what will be the treatment?
Yes,
we'll go to the treatment later. You can continue. Yeah.
Yes, this case, since there was no severe edema, so we gave the child a stress dose of steroids. That's the alternate day 1.5 mg per kg was converted into daily steroids of 1.5 mg per kg, and child went into remission by day 6, and now we are planning to continue on 1.5 mg per kg of alternate day steroids and slow tapering over 1 year, where after 6 weeks child will be if the child doesn't go into any relapse, child will be planned to taper into 1 mg per kg and thereafter into 0.7, 0.5 eventually. That is the plan.
Okay. So now at this point, what will be can you tell me the indications for renal biopsy?
Yes, ma'am. So the indications for renal biopsy will be if there is gross hematuria, there is hypocomplementemia, and prior to starting, if there is any late initial or late steroid resistance, prior to starting calcineurin inhibitors, and if there is any reduced kidney function during the use, there is any deranged RF.
Yeah. Whenever there is a persistent renal dysfunction, or if there is a persistent hypertension, and age.
Any atypical age group. The typical age group is not 2 to 6 years. So if the child, if there is any onset before or after that, it is an atypical age group. So,
yeah. So these are the indications for renal biopsy. Can you tell me the indications for doing genetic testing?
Yes, ma'am. Genetic
or
testing.
What genetic testing do you do? And what are the indications?
Yes, ma'am. So genetic testing, next generation sequencing is done in these patients. So next generation. Next generation. Yes, ma'am. Can you hear me, ma'am? Yeah, ma'am. So genetic testing, next generation sequencing is planned, and it is usually done in cases of congenital nephrotic syndrome or any age infants with age more than 12 years or infant onset, that is less than 12 months old, infant onset nephrotic syndrome. Then and if there is any family history of steroid resistance, then prior to renal transplant.
Yeah, okay. So that will be either whole exome sequencing or the NGS.
Yes.
What is the mutation that you look in NGS?
The typical congenital variant of nephrotic syndrome, which is a Finnish type mutation, ma'am. That is NPHS1 or NPHS2. Then there is the Danish-Trash syndrome, where there is WT1 mutation. Then there can be LAMB2 gene mutation, which is seen in associated syndromes like Pearson syndrome. Then other genetic condition like Galloway-Mohan syndrome.
Okay, good. Continue. Yeah. So we'll go to the treatment then. Can you plan treatment? You can just tell the treatment from the beginning. If suppose the child is presented to you in the as a first episode.
So the first episode, the complete dose and duration of treatment is very important, treating the child with the correct dose and duration of therapy. So in the first episode, until the child, so the first episode, 60 mg per meter square or 2 mg per kg per day, child is given for 6 weeks. And then after 6 weeks, once even if the child attains remission, after 6 weeks, then the child is converted into 40 mg per meter square for alternate day for another 6 weeks. Then whenever the child goes into relapse, during the period of relapse until remission, child is again started on 60 mg per meter square. And once the child attains remission, child is given for 4 weeks, 40 mg per meter square of oral steroids. Then for
So during the relapse, you give the initial treatment will be till the remission. That is 3 consecutive samples being trace or less than 1 plus, right? So this child is a frequent relapser and the child is on steroids. So what are the other options? What are the steroid sparing options?
So, ma'am, when the child is a frequent relapser, if there are features of, if there is any, so there are 2 categories that we consider. If the child is frequent relapser or infrequent relapse with steroid toxicity, and if there is any features of and not then we will and if there is any features of steroid resistance, then we can consider the child initially on levamisole or mycophenolate mofetil or cyclophosphamide, and
but not for steroid resistance, for frequent relapses.
Frequent relapses, yes, steroid dependent.
So steroid dependent. So what are the drugs you said?
Levamisole, mycophenolate mofetil, and
so which among this is the safest?
The safest will be levamisole, ma'am. Usually start with levamisole.
When do you give cyclophosphamide?
Cyclophosphamide is given when the steroid threshold, when the child is on a high steroid threshold, like more than 1 milligram per kg, and child is still, and there are any features of steroid toxicity or.
The most important factor that is given only for children more than 6 years, not for small children. Right?
Yes, ma'am. Yes.
Suppose a child is not responding to these simpler drugs, means like levamisole, mycophenolate. What are the other options?
We can consider calcineurin inhibitors like cyclosporin and tacrolimus.
So even in steroid dependent nephrotic syndrome, if you're going to start calcineurin inhibitors, you have to do a renal biopsy.
Yes.
You have to do a renal biopsy prior to initiation. And usually, what is the duration of treatment of this calcineurin inhibitors? What are the drugs? Calcineurin inhibitors?
Yes, ma'am. It is cyclosporin and tacrolimus. So initially,
so they are usually given for how long?
Ma'am, first for 6 months we give, and then we assess the response. So if there is any partial remission, then we continue it for 24 months. But if there is no response even to this, then we will have to switch to rituximab. After 6 months, we usually assess the response.
If the child is responding, usually it is given for 2 to 3 years, calcineurin inhibitors.
Yes.
So again, you have to do a renal biopsy even after that. Why are we doing renal biopsy specifically for calcineurin inhibitors?
To know if the child is, if there is any FSGS or any progressive.
Actually, the drug per se is nephrotoxic. So that itself can cause renal damage.
Yes.
So that is why we usually do the renal biopsy. That is in all the other drugs that are for steroid dependent, we usually don't do a renal biopsy. But before starting, in the event of starting a calcineurin inhibitor, you have to do a renal biopsy.
Yes.
Okay. Suppose the child is a steroid resistant nephrotic. Can you just tell, you just mentioned about the steroids and the other immunosuppressants. What are the other supportive care that has to be given to these children? So your primary treatment, you have told. What are the other factors that need to be considered during the treatment of nephrotic syndrome?
And we'll have to screen the child for any features of I mean, is that, ma'am, the question, that are there any features of steroid toxicity? Like we'll have to do ocular evaluation every 6 to 12
Yeah, that is there. That is about the primary treatment. Primary treatment and the complications of that primary treatment is there. Second will be the treatment of the different complications and the symptoms that the child is having. The child is having edema, as we discussed earlier. The diet, fluids, and albumin infusion, and the diuretics.
Yes.
Right? Suppose the child is having hypertension. What are the drugs that you use?
The AC inhibitors or ARBs will be started.
Yeah, when you use AC inhibitors, what do you look into? What do you monitor?
Some AC inhibitors like captopril itself can cause proteinuria, and then we'll also have to monitor
you have to monitor the renal function and the potassium.
Yes, potassium.
So what other drug that you use other than AC inhibitors that are commonly used?
Nicardia.
Calcium channel blockers.
Calcium channel
like amlodipine. So what will be the child is hypertensive and you're giving medication. What is the target blood pressure what is the target blood pressure range that you tell till when you give? Yeah.
Less than 95th percentile, the BP should be.
Yeah, the target BP should be 75 to 90th centile.
Yes.
Okay. So primary, we said primary treatment, edema treatment, hypertension treatment. Next is what? What is the other thing? What is the other component of nephrotic syndrome?
There can be infections, ma'am, which we will have to immunize the child.
Yeah, that is next. Say the other thing will be dyslipidemia, hypercholesterolemia.
Yes.
So you have to advise the diet, right?
Yes,
and for bigger children, you can even give
more than 6 HMG.
Yeah, you can even give statins.
Yes.
Okay. Then comes nutrition.
Yes.
That also we have discussed earlier, right?
Yes, ma'am.
Yeah. Then finally, about the treatment of complications. Treatment of thrombosis, treatment of infections, steroid toxicity, and any supplementation that you give.
We use the vitamin D supplementation, calcium, phosphorus, vitamin D supplementation is given to these children.
Yeah, that should be given. Yeah. So the treatment will include all these things, right? And you have to give a proper advice regarding immunization also.
Yes, ma'am.
Okay. Okay, that is a good presentation. I think,
Thank
sir,
you.
other senior sirs like Purushothaman sir, Anandakeshavan sir, anything to be added?
Akshaya, will you stop the screening?
Yes.
It was well presented and well discussed case. Very good present.
Thank you, sir.
Then in the initial presentation, what was the steroid at that time? Was she on immunosuppression?
So she was on 1.5 mg per kg alternate day steroids, sir.
Okay.
And then she went into a relapse.
Oh, from August 2024, she was steroid free after the first case.
Yes, sir. Just for 9 days.
Since the first relapse onwards, she was continuously on steroids. She was never free of steroids. Huh?
Yes, sir.
Almost 10 months.
Yes, sir.
So it's a very interesting thing is that in spite of that much of steroid, she didn't have any steroid toxicity. There is no growth suppression. There is no overweight. I was wondering because continuously 10 months steroid, that too 1.5 milligram per kg. Was he able to bring it below that level?
No, sir. We have still not been able to bring it below the level. She's still in 1.5 mg per kg.
We expect some problem. So in a case, this social situation where this child is with the grandmother, abandoned child, when the history doesn't fit with the finding, we need to consider the compliance part.
Yes, sir.
Because that's another possibility. Rather than branding it as not responding, in a situation where you don't see the steroid toxicity in spite of this thing, whether these relapses are due to the non-compliance, especially it's a grandparent looking after the child. Of course, grandparent affection and all will be there. You need to consider that possibility. That's all. Then in the initial presentation, you need to consider usual respiratory conditions, running nose followed by cough, fever, and you are narrating a lot of negative points. So there you need to consider an immunocompromised situation, how the physical findings and the complications will be manifesting. Because if the child is on a nephrotic syndrome with high dose of immunocompromise, the typical features of a complicated indrawing, the other things may not be there. So inflammatory response may be a little bit suppressed. That need to be considered. And when you're presenting the history of presenting illness, it should be onset, evolution, and the entire course of the first is to be completed. So that is not completed before you went back to the past history details. And you were presented very well the past history in the diagrammatic. That is a very good presentation. And in the second relapse, you had a complication of seizures. There, you considered, you referred to the pediatric neurologist, and their opinion was like that, and you did an MRI. In fact, rather than talking about the consultant's opinion, rather than talking about too much of the gadgets or investigations, what conditions you will be considering in such a situation need to be mentioned as a pediatrician.
Yes.
Pediatrician's point of view, when a 1 year and 6 month old baby is coming, already on steroids, presenting with a little bit unusual presentation during the edema, which you don't expect. So 1, 2, 3, 4, 5 possibilities need to be considered at that situation. You discussed that. One of the possibilities is simple febrile seizure. Is it a febrile seizure? Is it a meningitis? So in the investigation, what we expect was some of the common things, electrolyte imbalance and all. But meningitis is always important. You didn't mention about the LP, whether you did an LP, what was the findings? That was to be mentioned rather than neurologist opinion or an MRI. So what we expect, the common things always common. A child immunocompromised is likely coming with a seizure, which is unexpected during a relapse. Common things always need to be considered and ruled out. Of course, the cortical venous thrombosis, another possibility. All possibilities need to be considered clinically, and whatever your investigation, what it turned out to be at that time, that is a little bit incomplete during that detailing of the first relapse. And other things during the follow-up was well mentioned. And you, of course, considered all the steroid toxicity and all the deficiency situations, anthropometry and all. And in the one thing odd I found out was they do in the measurement, it was 13.4 as an expect of 13. But in a 2-year-old, 7-month-old baby with an average normal measurement of 50th centile, your mid-arm circumference was 16.5. A bit unusual measurement. All the other are okay.
Sir.
But what is the mid-arm circumference you expect in a 50th centile, otherwise height, weight and all? What is the mid-arm circumference you will be expecting in a 2-year and 7-month-old child?
It's around 14.
It won't be 16.5. Maybe you can tell that there is an edema. In that situation also it's not fitting because edema, the weight will be more than 13.4. So most likely whenever you are presenting a similar things, you can be caught in situation. That mid-arm circumference is unlikely to be right. Okay, the other findings. And one more thing is about the span of the liver, 6.5. Bit unusual. You said it is a 2 centimeter palpable soft liver. You expect a little more, I think. And in the respiratory system examination, you said there was a free fluid shifting dullness was positive. And very important, you mentioned the clinical features of a pleural efficiency was not there. You mentioned about the percussion and trough space also mentioned. That's very important because in a case, the respiratory rate was 29. Okay. So there should be something to account for that. So there is 29 respiratory rate is a little on the higher side than normal. So 29 is not a little on the higher side even for that 2-year and 6-month-old. So you need to consider, is there anything? In this case, respiratory system examination was otherwise normal. You need to recount this thing. Okay, otherwise all the presentations, all the discussions were all excellent. You covered everything. Well presented, discussed also, Sereena.
Sir, seizures ഉണ്ടായത് ഫസ്റ്റ് എപ്പിസോഡിൽ തന്നെയായിരുന്നു സാർ. സീഷർ ആൻഡ് DVT not during relapse, sir.
And that അവിടെ ഒരു again നേരെ അങ്ങോട്ട് പറയല്ല. There was an unexplained shock and which responded to albumin and all. Because usually in a case when you're suspecting nephrotic syndrome with the circulatory insufficiency, you need to consider other possibilities.
Yes, sir.
Hypoalbuminemia is a reason. അവിടെ ചെറിയൊരു ഇത് വന്നിട്ടുണ്ട്. അപ്പൊ എന്താണ് അതിന്റെ? You presented everything became all right on fluid and albumin. But a little odd ആയിട്ട് തോന്നുന്നു അവിടെ. Whether there was something else. Hypoalbuminemia as such will not be presenting like that. That cannot explain. But it's a real കാര്യമുള്ള. Okay, you covered everything. Akshaya.
Thank you, sir.
Well discussed. Anybody else? Anand has left, I think. Sajida ഉണ്ടല്ലോ. സാജിദ പറയൂ.
സാർ, ഒരു ഡൗട്ട് ഉള്ളത്, നമുക്ക് റിട്ടുക്സിമാബ് കൊടുത്തു കഴിഞ്ഞാൽ വാക്സിനേഷൻ അതിലെന്തെങ്കിലും നമ്മൾ വ്യത്യാസമുണ്ടോ സാർ?
റിട്ടുക്സിമാബ് ആണെങ്കിൽ ഒരു ലോങ് ഡ്യൂറേഷൻ ഈ കേസിൻ്റെ അകത്തൊക്കെ വരും. റിട്ടുക്സിമാബിന്റെ 10 months കാര്യം പറയുന്നുണ്ട്. ലൈവ് വാക്സിൻസിനാണ്
നമ്മുടെ പർപ്പിൾ ബുക്കില് റീഇമ്മ്യൂണൈസേഷൻ തന്നെ പറയുന്നുണ്ട്.
അതുകൊണ്ട് ബിക്കോസ് ബി സെല്ലിന്റെ സെപ്പറേഷൻ ഉണ്ടാവുന്ന കാര്യമുണ്ട്. ഫോളോയിങ് റിട്ടുക്സിമാബ് അതൊരു കാര്യം പറയുന്നുണ്ട്, റീഇമ്മ്യൂണൈസേഷന്റെ കാര്യങ്ങളും. പക്ഷെ അത് നമ്മളിപ്പോ കേസിന്റെ അകത്ത് റിട്ടുക്സിമാബ് വാസ് നോട്ട് ഗിവൺ അല്ലേ?
നോട്ട് സർ.
ബിക്കോസ് ദാറ്റ് വിൽ മോഡിഫൈ ദ ബി സെൽസ് 20 ഒക്കെ പോവും. അപ്പോൾ റീഇമ്മ്യൂണൈസേഷന്റെ കാര്യങ്ങൾ പറയുന്നത് ഉണ്ട്. പക്ഷെ പ്രാക്ടിക്കലി എത്രമാത്രം എന്നുള്ള കാര്യമാണ് നമ്മള്
പർട്ടിക്കുലർ ഡോസിന് മുകളിൽ കൊടുത്താലാണോ റിട്ടുക്സിമാബിന് അങ്ങനെ ഉള്ളത്, അതോ എനി ഡോസ് ഓഫ് റിട്ടുക്സിമാബിൻ?
അതും ക്ലിയർ ആയിട്ട് മെൻഷൻ ചെയ്ത് എനിക്ക് തോന്നുന്നത് ഹയസ്റ്റ് ഡോസിന്റെ സിറ്റുവേഷൻ എന്നാണെന്നാണ് എനിക്ക് തോന്നുന്നത്. ഇപ്പൊ നമ്മള് ഈ കേസിന്റെ അകത്തൊക്കെ ചില കേസിന്റെ അകത്തൊക്കെ മോഡിഫൈഡ് ഡോസ് ആണ്. നെഫ്രോട്ടിക് സിറ്റുവേഷൻസും അതുപോലെ തന്നെ ഈ പറഞ്ഞ TTP അല്ല HS ലൈക്ക് സിറ്റുവേഷൻസിന്റെ അകത്തൊക്കെ ചിലപ്പോൾ റിട്ടുക്സിമാബ് കൊടുക്കുമ്പോൾ ഈ ലോവർ ഡോസ് ഇൻസ്റ്റെഡ് ഓഫ് 375 mg/m² പകരം ലോവർ ഡോസ് ആയിട്ട് കൊടുക്കുന്ന കേസിന്റെ അകത്തുണ്ട്. ഇറ്റ്സ് നോട്ട് ക്ലിയർലി മെൻഷൻഡ് ഫോർ വാട്ട് ഡോസ് ദിസ് ഈസ് ടു ബി റീസ്റ്റാർട്ടഡ്. അപ്പോൾ അത് നമ്മൾ പ്രാക്ടിക്കലി ചെയ്യാറുണ്ടെന്നും തോന്നുന്നില്ല, കാരണം അങ്ങനെ റെക്കമെൻഡേഷൻ കണ്ടെങ്കിലും. പിന്നെ ഈ കേസിന്റെ അകത്ത് വാട്ട് ആർ യുവർ പ്ലാൻസ് ഇൻ ദിസ് കേസ്? Because in this case, as long as you are not getting steroid toxicity, should be step up for other immunomodulators or not. Ideally, it's not needed. But it's a real idea. It's not fitting with whether non-compliance in the situation undo. എന്നുള്ള കാര്യം കൂടി അവിടെ നോക്കാനുള്ളത്.
അത് കറക്റ്റ് ആണ് സാർ. അതെന്ന് വെച്ചാൽ സ്റ്റെറിയോടോക്സിറ്റി എന്നുള്ള ഗ്രാൻഡ് മദർ ആണ് നമുക്കൊരു ഡൗട്ട് ഉണ്ട് സാർ.
സാറേ താങ്ക് യു വെരി മച്ച് സാറേ. പുരുഷോത്തമൻ സാർ ശബ്ദമില്ല സാർ. സാറിന്റെ പോയിന്റ്സ് ഭയങ്കര വെരി വെൽ ടേക്കൺ. അതായത് മറ്റേ ഗ്രാൻഡ് മദർ കൊടുക്കുമ്പോൾ കംപ്ലൈൻറ്റ്സ് ഒട്ടും ടോക്സിസിറ്റി ഇല്ലാണ്ട് വരുന്നത് നമ്മൾ അങ്ങനെ ചിന്തിക്കുന്ന ഭയങ്കര നല്ലതാ. പിന്നെ അതേപോലെ ആ റെസ്പിറേറ്ററി റേറ്റിന്റെ കാര്യം എനിക്കിപ്പോഴും ഓർമ്മയുണ്ട് സാർ. ഞാൻ ഫസ്റ്റ് ഇയർ വരുമ്പോൾ റെസ്പിറേറ്ററി റേറ്റ് ഭയങ്കര സാർ പിടിക്കുന്ന ഒരു സാധനമാണ്. അതിപ്പോഴും അത് എന്തുകൊണ്ടാണ് അത്രയും ആ ഒരു ടാക്യുപ്നിയ വന്നത് എന്നുള്ളത് നമ്മൾ ചിന്തിക്കേണ്ടതാണ്. താങ്ക് യു വെരി മച്ച് സർ. ആൻഡ് ഡോക്ടർ സെറീന and Akshay also presented very well. Sunil sir, thank you sir. Thank you very much.
Thank you, ma'am.
Maybe we can wind up അല്ലേ? വേറൊന്നും ഇല്ലല്ലോ?
Yes sir, we can wind up.
Anyway,
Yes.
Completely you have touched every area. Very good presentation, both of you.
താങ്ക് യു സാർ. താങ്ക് യു സാർ.
Akshay second year ആണോ?
ഇപ്പൊ third year, sir.
3 years.
Okay.